Thanks so much, everyone. These are my disclosures. None are relevant to this talk. And I think it's helpful as we do this to just define what we mean by ERAS. And so this definition of ERAS, I think, is a very good one. ERAS can be defined as a multimodal, multidisciplinary, evidence-based perioperative care pathway designed to optimize patient outcomes by accelerating or reducing the surgical stress response and accelerating recovery and minimizing complications. And I think I underlined the parts that I think are critically important here: the multimodal and multidisciplinary nature of this process, and with the ultimate goal of optimizing patient outcomes, both short-term outcomes and long-term outcomes. And I think it's helpful to have a case example that we can think through as we think about how we do this for our most complex patients. So this is a 47-year-old woman that I took care of who came to me having had 10 prior operations. And this all started with a fairly straightforward selective thoracic fusion, but then she had a revision after that resulted in a spinal cord injury and temporary paraplegia from a misplaced screw. She had a cardiac arrest after that operation. She then developed neurogenic pain with a large thoracic syrinx. She ended up needing an intrathecal baclofen and morphine pump. And then ultimately someone thought maybe the screws were the cause of her pain and just removed all the screws. So she came to me with a progressive cervical deformity with a chin-on chest and cervical myelopathy, as well as a multi-level spondylolisthesis below, causing a lumbar radiculopathy. In addition to the history I already described, if you see her physical exam, she also came with lymphedema with an open wound on her leg. She had intrathecal baclofen pump, as I described, and was a chronic narcotic user. She was not a smoker, thankfully. She also had significant wound issues. You can see the atrophy of her paraspinal musculature up in her cervical spine and the zipper ready for her next operation. These are her alignment parameters. So she had a significant cervical kyphosis with forward head posture. CT scan showed severely distorted anatomy. So you can see the amount of bone from her prior operations with really no landmarks. Multi-level spondylolisthesis. You can see the large syrinx in the upper thoracic cord. So when we think about this patient, it can sometimes be overwhelming. How do we get this patient from point A to point B and get them through this operation successfully? And I think that we always think about the surgical factors. After all, we're all surgeons, right? So we think about the carpentry of it all. And these are some of the things we think about. How are we going to position their head during surgery? What issues might we experience during exposure? How are we going to instrument the spine safely when there's all this distorted anatomy? What type of monitoring are we going to have? Are we going to have abnormal signals to start the case, and how might that affect things? What are our releases going to be? How are we going to use TXA? How are we going to actually assess our alignment? But there's a lot of other factors that we have to optimize too to make sure to get this patient safely through her operation. And so we're going to have to deal with the baclofen pump. If that gets cut, is she going to have withdrawal? Is our anesthesia team even capable of handling this type of case in our hospital? What other services might we need to utilize, whether that's general surgery for anterior exposure, whether that's plastic surgery, given her 10 prior procedures? Is the post-procedure care and is the system actually resourced to take care of a complex patient like this? Do we have a team in place to actually answer the inevitable phone calls that we're going to get after this sort of an operation? And how do we best identify the patient-specific factors that might inform us with regards to this particular patient's risk? And how do we make this person the best version of herself prior to surgery so that she can have the best possible outcome? So we can think of this in terms of non-modifiable risks as well as modifiable risks. The non-modifiable risks, we don't have much control over. We can't change her age, can't change the severity of her deformity. We can't change what sort of social support system that she has at home, family members that are able to help take care of her. But we can change all of these modifiable risks. And these are things like her bone health. If they're diabetic, getting control over their diabetes. If they're deconditioned and frail, we can have them participate in a prehabilitation program. If they're a heavy alcohol user, we can get a program in place to get them to stop that. And then also managing their psychological status if they are someone who perseverates on pain or doesn't have systems in place to deal with that. And just also setting appropriate post-operative expectations so that they can understand what it's going to be like to go through this operation. We've written about this extensively and how we optimize these patients. And in our program, we have a team approach where we have a multidisciplinary program involving all of these different team members. And all patients like this are presented in a multidisciplinary conference involving spine surgeons, both neurosurgery and orthopedic spine surgeons, a dedicated complex spine anesthesia team that is there, so they understand exactly what we're going to be doing during the operation, what the physiologic load is going to be during that surgery. We have internal medicine doctors. We have our spine clinic nurses, our research staff. But importantly, we also have pain management doctors and neuropsychologists that actually understand the psychosocial aspects of this patient's care and how we optimize them from that standpoint to get them through this type of operation safely. We do a lot of preoperative planning. And in addition to the preoperative planning process, the intraoperative execution ultimately has to be superb. And so again, we talked about the dedicated complex spine anesthesia team. These sorts of the most complex cases, we use either 2 attending surgeons or an attending and an experienced complex spine fellow. That way we can get through the operation safely and efficiently. Using enabling technology as necessary, in this case, we built a 3-dimensional model of our spine so we could see and understand exactly what that spine would look like ahead of time to pre-plan all our screw trajectories and know where we might anticipate any difficulties. All of these things are done to make sure that we can optimize our OR speed and efficiency to reduce blood loss and complication rates. We also perform detailed intraoperative tracking, and so patients get hourly labs during the operation so that we can identify any rises in fibrinogen level, any creeping up of the INR, so that we can act on that very quickly and proactively to make sure that the patient is not having a physiologic decline towards the later stages of the operation. With all these protocols in place, less than 1% of our patients go to the ICU after surgery, and this patient also went to the floor after surgery, not to the ICU. So this patient ultimately underwent this operation and had an anterior and posterior reconstruction from C2 to the pelvis. She's now 2 years post-op and actually back to work for the first time in 10 years after her operation. You can see her alignment parameters are ideal and match our preoperative plan. And so it's important to remember that preoperative optimization is not just medical clearance, right? It's needing to optimize all of the preoperative, intraoperative, and postoperative phases of care. And it's really critical to involve a multidisciplinary team for these most complicated patients, because as surgeons, we can do our part critically, but if all the other pieces of the puzzle are not in place, these patients will not have their best outcome possible. Thank you so much.